So just to briefly introduce the topic and who we are. So I'm Mike Ward. I'm from Vanderbilt University in the Nashville VA. And we're going to be talking about VA emergency care research hiding in plain sight. And so I'm going to introduce my colleagues, Anita Vashi from the Palo Alto VA, and then Comilla Sasson from the Denver VA as well. Candace McNaughton also was a valuable contributor on this and also another VA emergency medicine researcher. So we'll try to get her incorporated in this too. What we're going to do today is we're going to talk a little bit about VA emergency care, just to give you kind of an orientation to VA emergency medicine, because it's something that's not entirely familiar to everyone, as well as how the VA Office of Research and Development is organized. We're going to have just a brief panel talking about how you got involved in research, what you're doing and where you're going, and then really how to get started in emergency care research in the VA. This is really meant to be more of an informal session, so we want you all to ask questions. We recognize that the VA can be something that's somewhat hard and difficult to break into, and that's part of the reason for this didactic in the first place. So I'm going to go ahead and let Anita Vashi go ahead and start, and we'll go from there.
Good morning, everyone. So like Mike said, I thought it would be a good idea just to start with like a brief overview of what EM looks like in the VA. I think there's about like 25 million-ish veterans in the U.S., and of them, about 9 million or so are enrolled in VA care. VA care is delivered across 19 regions, or what we call VISNs, integrated service networks, and at 172 medical centers. Of those 172 medical centers, 141 have an ED and urgent care. We also provide care across over 1,000 outpatient clinics. Every year there's about 2.5 million ED visits, and the VA provides care obviously at their own VA emergency departments, but they also, in some situations like when veterans live far from a VA, they pay for care at non-VA emergency departments. And there's about 500,000 of those visits every year that the VA pays for. And of course, what this does not capture are some non-VA emergency visits that the VA does not pay for. So just a brief overview of how research is sort of organized in the VA. We have our executive in charge of the VHA, and then underneath that executive, there is an office called the Deputy Undersecretary for Discovery, Education, and Affiliate Networks. That right now is headed by Dr. Carolyn Clancy. And within that group, there's the Chief Research and Development Officer, which is responsible for overseeing kind of 4 arms of research within the VA. We have the Biomedical Laboratory R&D Service, which is primarily concerned with conducting preclinical research focused on molecular, genetic, and physiologic levels. We've got the Clinical Science R&D Service, which is focused on moving ideas across the translational pathway from scientific discovery to clinical application. And examples include interventional and effectiveness studies, clinical epi, and technology studies. Then we have HSR&D, which is, I think, the group that we most are affiliated with. And that kind of encompasses all aspects of VA healthcare, focusing on patient care, quality, and cost. The mission of HSR&D is to identify, evaluate, and rapidly implement evidence-based strategies that improve the quality and care delivered to veterans. And something to point out, if some of you are familiar with some of the groups in the VA, the group called Query sits within HSR&D, and Query is focused on implementing evidence-based strategies and improving quality. So it's more about the QI arm of research. And finally, we have the Rehab R&D, which is focused on research and technology that improves the quality of life for impaired and disabled veterans. So next to talk about some of the ways that you can get funded in the VA to do the research that you're interested in. The VA has a robust CDA program, and you can apply for a CDA with any one of those 4 research groups that I just went over. We also have the IAR program, and so that is investigator-initiated research, where you can pursue your sort of personal research interest while advancing some of the HSR&D priority areas. The funding is like a competitive process, and all the proposals undergo peer review, and it's probably the most common way to get your investigator-initiated research done in the VA. Next, we also have a service-directed research, and that's research that's solicited by HSR&D for special issues. So some of these projects are conducted in response to mandates and requests from a variety of constituents, including Congress, federal agencies, and other operational stakeholders. They kind of put out these solicitations through announcements, and then if you're interested, you submit a concept paper, and if it's approved, you do a full project proposal, and then they're reviewed by peer review and selected for funding. So current active projects in this area address issues ranging from hypertension, MS, prostate cancer, diabetes, substance abuse, spinal cord injury, HIV, and evaluation of healthcare costs. And the program, a Query program that I mentioned earlier. Query is a group that includes 40 national programs. They also put out solicitations for partnered evaluation centers, implementation strategy, network hubs, and other initiatives across the U.S., again, to encourage uptake of effective practices and evaluation of new programs and initiatives that are aimed at quality improvement. Other special funding situations include things like operational partnerships. So, for example, like the VA has a lot of different programmatic offices, like the Office of Rural Health or the Office of Women's Health, and so oftentimes they have a large budget to do sort of program work, and they will use a portion of their budget to partner with researchers to do either evaluations of the project or just answer questions that they have that they can't take on, and that's something I think we'll all talk about. And finally, I just want to share with you guys some of the priority areas in the VA. And because I think a lot of times some people think like, oh, like what I'm interested in, I can't imagine that the VA is interested in, but you'll see that the kind of priority areas are cross-cutting, and you can often translate what you're doing maybe outside the VA to VA focused work.
One thing to add real quick, so when we talk about 500,000 visits from the VA being paid for that are occurring outside of the VA spent over $1 billion on non-VA emergency care. And so when you talk about really being able to get their attention, that is a tremendous priority area that Anita and I believe David Chan are also working on as well. So it's we'll get a little bit more into our experience, but Comilla is going to go ahead and lead the panel now.
Mm-hmm. And we're going to start it off with some questions, but we want to open this up to you guys for the types of questions you all have as well. So we're going to kick it off first just by asking everybody here, how did you get into the VA specifically for your research? So Anita, we get to start with you.
Sure. I got to the VA by accident. It's a long story, but I was graduating fellowship, and I thought I was heading to D.C. to work in policy with Medicare. And that was the year there was a big budget sequestration, and my job got frozen. And so a month before graduation, I had no job. And so I restarted my job search and kind of cast a wide net. And one of those was this HSR&D center in Palo Alto. So I kind of contacted the person that's not my boss and had several conversations about VA, what research in the VA looks like. And it was something I'd never really spent a lot of time in the VA or working in the VA, so I had my own kind of perceptions of what that was like. And I was a little nervous because I hadn't spent a lot of time there, but it's one of the best decisions I made, so I'm really happy about that.
So I think I share a similar theme in that mine was also by accident. So I had, if you asked me 5 years ago whether or not I'd be up here, or sorry, 6 years ago, doing this panel, the answer is absolutely not. I had no expectation that I would be involved in VA emergency medicine research at all. So 6 years ago when I came down to Vanderbilt, I had a clinical appointment as part of coming down there. And didn't really think much of it, but everyone kind of kept saying, you know, your work really aligns well with what the VA does. And I was like, all right, well, maybe I'll put in a career development award to the VA as well as a K-23 and got exposed to the process and how differently the VA thinks compared to NIH, how much more systems-oriented it is, which really aligns with my work, which is in more operations research and in care transitions, as opposed to more disease-oriented research that would align better with NIH and other funding sources. And although my CADA didn't get funded, I kind of always kept that in the back of my mind. And Candace and I had the good luck of getting connected with what's called the MFAC, the Emergency Medicine Field Advisory Committee, which advises the National Director of Emergency Medicine. And one of our contacts through that became the National Director, and he asked us to become more involved in VA emergency medicine research, and it it snowballed after that. So I share the accidental finding of VA emergency medicine research, and frankly, it's been a great option and a great complement to non-VA research.
And I actually started at the University of Colorado and started doing some shifts just part-time at the VA, just on an intermittent basis, and got exposed to the patient population, which I really liked and really enjoyed, just because it's a different patient population than I was seeing at the university. And I will say that the opportunities for true systems-based care and health services research are so much greater sometimes, I think, in the VA, because there's already huge databases there. There's a lot of program-oriented money that's floating around, and they're very much implementation oriented. And so it's not necessarily the traditional 5-year pathway to getting, from idea to actual program implementation. They expect you to do program implementation on day one and start iterating on that and evaluating it kind of in situ. So it's sort of, I think, a nice mix of being able to do operations-based research, have a patient population that we don't necessarily get exposure to. And in our group specifically, we are 95% EM board certified physicians, which isn't necessarily all how it is across the entire VA, but it's definitely the shift that we're seeing. And I think the nice thing about being part of the VA EM structure is that it's a small group of us. And so usually when there's anything that touches the VA emergency department, one of us gets pinged and says, hey, you should apply for this. Sometimes you've got 36 hours to go apply for this, but I do think it's kind of a nice community as well if you want to look to other health services researchers. I was an RWJ clinical scholar at Michigan, and so the exposure to the VA is I think, kind of ingrained in you because they're such strong partners for the RWJ program. And I think that carries through in terms of all the research that we do as well.
I think Comilla has nicer friends than I do.
What was that?
I said I think you have better friends than I do.
All right. So what kind of things are you studying? So Mike, we'll start with you first.
I kind of briefly alluded to it, but my work is specifically focused in the VA is focused on care transitions, and so my K-23 is on interfacility transfer patients with STEMI and better understanding facilitators and barriers to timely transfer. And so Candace and I actually put in a award application to the Office of Rural Health looking at interfacility transfer of rural veterans. So translating some of what we did in my K-23 to the VA. And it's basically a mixed methods analysis of these transfers. And so it's actually been a great experience going around to a number of these rural VAs and just seeing, really how kind of the other half of life lives. And it's just been really eye-opening. As part of this, we've implemented telepsych in the Tennessee Valley and are looking to expand that. And this has just taken me in a direction that I never thought. Again, go back 6 years and ask if I'm going to be implementing telepsych in the VA. The answer is a flat no. And then, so we've got that. And then also just put in a merit application that got a favorable score, and it's going to go back in about 2 weeks on developing a scalable feedback system for emergency care providers using human factors engineering to try to develop a feedback system that is intuitive to emergency care providers and that looks at quality of prescribing of antibiotics and NSAIDs, and how that affects adverse drug events in the emergency department. So a number of other things going on, but those are the two main areas of focus.
I think the big thing that you've really highlighted is, again, there's sort of a systems-based approach that you have to go into every VA grant with. So if you come in saying, I just want to work on STEMI and I want to see how dual antiplatelet therapy works post stent placement, you're probably not going to score well, right?
And that's actually, so in my,
Yeah.
so I put in a CDA to the VA and a K-23 to NIH, and I tried to take the same approach, thinking, oh, I'll just, double dip and try both. And in my initial application, the VA was like, who cares? It's only STEMI. And this was coming from a cardiologist. And it was just mind-boggling to me that in the NIH world, they're like, oh, this is what matters. This is the most important. Whereas from the VA standpoint, they're like, yeah, but it affects so few people. And that was really eye-opening to me and made me realize that I had to completely reframe how I was approaching this. And interestingly, it completely complemented my K-23. So then when I went back with my K-23, I had actually addressed the problems that they had in my initial submission, and then got my K-23 funded primarily from what I had done as part of my VA CDA and the proposal in that.
Anita?
In my head, I kind of divide the work that I do into two sort of buckets. The first is sort of my EM-related interests, and so for those projects, I kind of followed the more traditional route of applying for the investigator-initiated grants, and so I went, I did a pilot proposal, so that's a 1 year, $100,000 project where setting up a data infrastructure and things like that, and that kind of parlayed into applying for a IAR, so that's sort of like the 3-year, $1 million project scope, where we're looking at veteran access to emergency care, both in and outside the VA. And it's doing some, looking at data within the VA, but also doing some qualitative work as well. And then in my sort of other bucket of work, I've been doing a lot of query-related work, so that was that kind of quality improvement group within the VA. And so I led 2 partnered evaluation centers. One that was, so what's kind of cool about those projects is you are directly partnered with an operational partner. So for those of you that are familiar with like CBPR, it's very similar methods in that way, in which you kind of are coming up with evaluation questions and design with your operational partner. So one, for example, was evaluating the VA's lean enterprise transformation rollout through like 20 different pilot sites in the VA, and then the new one now is the VA Innovators Network, so we're doing evaluation of that program. And then, like we were talking about earlier, there's always some operational funds that are floating around, especially towards the end of a fiscal year, so I've been lucky to take advantage of some of those opportunities where, for example, there was the National Quality Group was interested in looking at some readmissions data, and so we got some money from them to do that work. And then more recently, there's been funds available for doing work related to opioids. So that's been another avenue of getting funds and getting our work done.
And then I think my interests really are kind of based on what do I see in the ED as being the biggest issue right now that I hate dealing with at 2 o'clock in the morning when I'm doing a night shift. And so that's probably how I've picked most of my research projects, which have aligned very closely with also operational dollars as well. So I had a tele-mental health grant through the Office of Rural Health where I was able to get some operations dollars to pilot a tele-rural mental health program. So we were able to start building the connections, and now we're actually doing that program kind of on its own that's living within the Department of Psychiatry. And then the other project that, along with Anita, got funded was around using the CARA-funded dollars to do an ED opioid safety initiative program. So we initially rolled out to our Denver program first, or Denver site first, with a dashboard on opioid prescribing rates by provider, so that they actually had very specific metrics on how many opioids they were prescribing, how many people were getting discharged, and giving them essentially a very crude metric of that. Creating an ED OSI toolkit that was very much tailored to the emergency department with an ALTO pathway as well. And then implementing that in Denver, implementing it in the VISN with our academic detailing partners who, give their time for free, which is a huge resource, having pharmacists who are willing to work with you all the time. And then from there, we've now rolled that out nationally and shown a relative 54% decrease in opioid prescribing nationally within about a year and a half. So then that's led to qualitative, quantitative work to look at increasing naloxone distribution and MAT initiation in the ED, and then we're piloting a program here in Denver starting June 1, where we'll do MAT initiation in the Denver VA with the idea of hopefully rolling this out within a year. And so I think the organizational partners and the access that you have to people who truly are on a national level who find interest in the work that you're doing, I think is pretty amazing. And it's not something that I've ever really been able to do before, but writing a grant and saying I'm going to implement 142 emergency departments, everyone would just be like, there's no way, right? Like that would be the first comment from the reviewers. But because we have academic detailers that are already detailing each of these hospitals, you've got this workforce that can really help you implement these types of programs. So with that, what do you see as being the biggest challenge to working in the VA? Anita, you get to start.
I think just getting started. There's a lot of startup costs. I think just navigating, because it's overwhelming. I mean, it's sort of like once you figure it out, it's a great advantage. But in the beginning, it's just overwhelming. You don't know who to go to for what because these things are on a national level. So even getting access to data, all of that first kind of 6 months, it was a challenge. And then I would say the ongoing struggle for me has just been HR and hiring competitively in the VA for your project staff has been a challenge. Yeah.
I'm glad you figured it out because I'm still waiting. And I really agree with that. The thing that I've found is that a major problem is really knowing what you don't know, and there certainly are administrative barriers, but that's where mentoring is so key in the VA, and having those around you and having a network of those who have done it before. It's even more so than trying to navigate it in the non-VA world, because it's almost like you'll run up against barrier after barrier after barrier, but then if you know the right person, suddenly that barrier goes away, and they know exactly how to get past it. And that's where it's sort of the institutional experience that's so incredibly important in the VA.
And I'll say my biggest challenge has just been, we became a department about a year and a half ago, so we were part of ambulatory care prior to that. And so becoming our own department, I think, has had its own administrative challenges. And there's not necessarily a culture of research. And so right now, our department is very clinically ops-oriented, just like you would think with any other kind of burgeoning ED that is also kind of learning how to have a mix of clinicians and researchers. And so we're sort of a $1 in, $1 out kind of shop right now, which I think makes it challenging. Is that going to change in 10 years? Probably, if there's enough of us that choose the VA as a home to do research. And so I think that's part of the plea, if you will, for today, which is considered as sort of this, once we have a growing mass of people and we have that cadre of pipeline of folks that are doing it, I think it's only going to get easier. So I think in a lot of ways we're dealing with the first people trying to do this work and really trying to understand what VA EM research really means.
And it's interesting too, I think a lot of people think, oh, well, I can make the VA better. We know how to do it better, and coming into the VA saying we're going to take our approach, as opposed to recognizing the approach that's already within the VA and building off that, because it's actually pretty darn good what they've got. There's certainly logistical challenges, but in this, ties into really what the next question is around sort of opportunities, and building on Camilla's comment, the scalability is tremendous. Even though, the expression of if you've seen one ED, you've seen one ED is certainly true in the VA. However, they have common roles and much more standardization across facilities. So even though each facility has their own challenges, they are still quite unique. In many ways, if you want to implement something at, like you said, 141 emergency departments and urgent cares nationally, you have a much higher ability of being able to do so. Plus, there's an alignment of interests. You want to take care of veterans, and you can get people on board much more so when doing that.
So what are the other opportunities that you guys see for the VA, working in the VA system?
I think there's a lot. I mean, for me, I also did the RWJ Clinical Scholars Program, and what I alluded to is I was kind of headed more in a policy direction than I was a research direction initially. And because I just wasn't sure that sometimes I worried that when I was doing research in a vacuum, like just answering questions I was interested in and writing papers that maybe somebody would read or maybe not. And that feeling does not exist for me in the VA because everything you're doing feels so relevant because it is so partnered, and that's the part that I really love. Like, you have these really excited partners that like are hungry for the results that you have and the findings that you have. So for me, that makes it more. I'm more engaged in the research process, and it feels you feel useful. So I enjoy that part of it, and you have. Like you said, you can scale up, which is nice. Part of it is because there is that standardization, but part of it also is, I mean, we can do things in the VA that you can't really do somewhere else, right? Like, we have mandates. So, for example, one of the things in my grant is I'm going to add a few questions to this national survey that goes out every 3 years. And it's a required survey that all ED directors have to reply to. So it's a 100% response rate of 141 ED directors. So that's pretty awesome, you know.
It's not short.
Yeah, exactly. So that makes it easier to do things sometimes. And I think just the willingness for people to think about new ideas and support them has been really great. And I would say that another thing I've enjoyed is the national network. I think you were kind of alluding to that before. Not only of in the ED, but like for mentorship has been really great for me. So, you know, I have great local mentors, but one of the best things that my mentor, Steve Ash, does for me is connect me with people across the country. And so I've been co-PI on some of these partnered evaluation centers with people in Boston or Durham and Portland who I've like never met in real life until we actually started working on our project. And that's another thing, like with the VA, I think they encourage collaboration, which I really like. It does not feel competitive at all. For example, in one of our partnered evaluation centers, they selected 3 proposals that they really liked. We were all approaching the question in different ways, and what they asked us to do was, will you guys be willing just to create one big like super group? And so that's sort of how I got into this partnered evaluation center with folks from Durham and Portland and Boston, is because we each had our like 3 or 4 different proposals, and then they asked us to kind of come together, which at first felt like kind of awkward, you know, but it's been awesome, and you learn so much from the folks at these different centers that have different skill sets, and you just have access to resources that are national. So whether it's like qualitative expertise, quantitative expertise, different like content areas, like it doesn't have to be at your local place. It doesn't have to be in people in the ED. In fact, I work with non-emergency people primarily, but we have like health economists that are at our center. We have PhD, like clinical psychologists and stuff that have a lot to contribute. So it's been fun to have these unique collaborations that I don't think I would have had outside of the VA.
And I will say from just an operational standpoint, again, most of my PhD has been in health services research. My prior to this, most of my research was in cardiac arrest and GIS and spatial analysis, and so I got to working in the VA, and now I sit on the National Medical Advisory Panel for formulary decisions because I got to know all the PBM, pharmacy benefits management people from doing my opioid research, and so I get to sit with 10 other physicians that determine what's formulary, non-formulary for the VA. And so that's an opportunity that would not have come my way had I not sort of dipped my toe in the water of sort of, being willing to step up and do some of these projects. I got to do a flow academy for a week and then spend a year with a bunch of flow specialists learning how to improve flow in my hospital. And that's, I think, been really eye-opening from not just from my research perspective, but also just really getting a better sense of how the ED fits into the massive organization of the hospital itself. And so these are learning opportunities that are free for VA faculty to go and be a part of. And that's, again, I think, another opportunity that you wouldn't necessarily get because VA does really invest a lot in their researchers and their clinicians as well.
And I think that's also a great point, too. I mean, the issue of how do you frame emergency medicine beyond the ED? I mean, what we do, we take care of patients for a very brief period of time, some albeit longer than others. But the question is, what's the role of acute care, emergency care in the broader veteran health? And that's the thing. So when you go before a study section, they're going to say, I don't care about something that takes 10 or 15 minutes. The issue is how long will it have an impact on the veteran's care? And so reframing what you do in that lens really helps you even in your non-VA applications to say, look, what we're doing is much more significant than we ever had framed before, and has made me think of it in that lens, which has been very helpful.
So we're going to open it up to questions from the group. Do we? Oh, that's right. Yeah, one more resource, and then we'll open it up to questions.
So getting back to the idea of how do you get started and what are some potential resources for getting started. So we put together this list, and I believe that a copy of the slides is available through the SAEM application. But if for any reason you have a problem getting it, let us know, and we're happy to get you a copy of this. First and foremost, every other week we have a call of VA emergency care researchers, and we can absolutely get you on it. All you have to do is let us know, and we'll add you to the list. We have a great group of interdisciplinary researchers who care about emergency medicine who are on this, anywhere from primary care to geriatrics to more methodologists that are involved. And so this has been a tremendous resource for being able to bounce off ideas from the group, know what else is going on, being able to build a network. Hey, can you be involved in this with me? So highly recommend that. There are different forms of fellowships, innovation, informatics, quality scholars that at least 2 people in this room have been involved in that are great from the standpoint of quality improvement, learning more about research, learning more about VA data. I can't speak tremendously about the innovation and informatics fellowships, but I'm aware that they're available. One thing that I'm really excited about, we just got EMF to approve the VA Fellow to Faculty Award. So this is $100,000 per year for 2 years. For that sort of time when you're trying to transition between being a fellow and faculty. And so we just had our first that will be awarded. And I just got word that they're going to do another one for next year. So I'm planting the seed now. I am happy to talk to you about it and happy to tell you about what we're looking for. We had some great applications last year, and really excited to see this continuing to move forward and to have EMF support on this. There's also the VA Data Bootcamp, which I believe is at Palo Alto, to learn about how to navigate VA data, which when you're coming in as an outsider is one of those things that is just a great way to be able to get started in understanding what's available and how to access it. VA cyber seminars. You want to know about what's going on in the VA and who's doing it? Get on one of these calls that anybody can get on. They're also recorded and uploaded and available outside of their intranet. And so you can go back years looking at what someone's done on, how do you get started in what's called Vinci, or who's doing work in relational coordination. You can go through this tremendous catalog of resources. Then there's obviously funding. Anita alluded to these, so the CDA or K equivalent mechanisms, pilot awards, which are like a smaller version of an R21, and merit awards, which are R01 equivalents. Here's a link to the HSR&D priorities, which we had on one of the prior slides, but gives you a sense about the things that they really care about. And they can be broadly defined, but when you think about how does this impact veteran health, that's really what they're trying to get at, and being able to build the significance around that. There are also a large number of VA academic affiliates. I think it's something like 79% of the VA medical centers have academic affiliates. Sometimes you don't even realize that there is already an established academic affiliate. It's that typically it's not taken advantage of. There might be some historical issues that perhaps your prior chair just doesn't want to get involved with it or had a bad experience. But I've noticed that there's been more openness towards the idea of building those relationships because there are so many resources and there's so much that's going on within the VA. At our shop, we've gone from being a, essentially business hour only EM board certified shop to 24/7. We have no fellows anymore. We have multiple coverage. And so, I mean, we are a full-fledged emergency department now. And then finally, there are the 18 centers of innovation. So they each have their different foci, whether it's measurement science or I think mental health. I mean, there are a wide number of areas of excellence within the VA that basically bring a tremendous number of resources to that setting. And so you have to basically have the equivalent of 5 individuals who have funding, whether it's pilot, CDA, or merit level funding. So it's 5 unique individuals to even be able to apply for this, which then brings a number of other resources. So it's almost like center funding. And so those are other ways to get a sense of what's actually available. Sometimes I've talked to individuals who are at the academic affiliate and don't even realize that they have one of these what are called coins at their VA equivalent, missing out on all these amazing resources in implementation science and qualitative work that are just sitting right there waiting to be tapped into. So what we wanted to do at this point is leave enough time for questions. I think they want us to use the mic so that the questions can be recorded. But really want to open this up to you all because we recognize what a perceived challenge it can potentially be, but at the same time really let you know that there are resources and there's a burgeoning network of individuals who are doing this work who want to help you get started. And I'll also say that the National Director in Emergency Care, Chad Kessler, out of the Durham VA is great. He is such a pleasure to work with and really help you get started.
All right, I feel like Phil Donahue. Who's got a question? All right, anybody? Any questions, Phil?
Camilla, is the mic on?
Is this?
Yep,
Yeah,
that's
you're
working.
good? Okay.
Hi, thank you for that presentation. My question is, so we are a hospital, University of Maryland, and we have a VA that's robust and all EM trained people, residents rotate through, et cetera. But we are, I don't work there, my husband actually works there, but we're contracted with the VA, so we're not VA employees. So I asked this question earlier, but outside, but how do you, as a non-VA employee, how do you access all of this and try to get that data and try to do programming and innovation?
Yeah, so we started talking about this outside a little bit, but I would say the first step I would take is join our Thursday calls, because then you have like personal connections with people that can help you out for sure. 2 is the walk process, which is work without compensation. So that sort of, it gets you like the ID badge and all the things, the passwords and stuff that you need to access the VA system. It's a process. It's like, depending on what center you work at, it can happen anywhere between 3 to 6 months. You got to do the fingerprinting, background check, the whole deal. So it's a little painful, but it's not like hard. You know what I mean? So that would be the first step. And then once that's in place, like to apply for funding, or there is a rule that you have to be 5/8 VA. The VA works in 8ths, so I'm a full-time VA person, I'm 8/8, so you have to at least be 5/8 to apply for funding yourself. But if you want to partner with folks on research, you can do that just as a walk and then tap into people. Like if you want to do something that's big, the big data related thing, like that's something that, I do with other people sometimes, and like in different, content areas, we all could probably do something similar.
So you can, if I wanted to mine the data for a question, I could work with somebody not at that particular VA. I could work with any of you guys, that kind of thing. Like, so, okay.
Yeah, that's the best part, is it's a national network. So I've definitely partnered with people like in Michigan and people who I've never even seen or met before. But yeah.
As long as they have access to the data, and if they own that database, then that's sort of, or they have access to that database, then you can work with any of us, right? So I do a lot of work with the pharmacy benefits management database. I think you do a lot more with like the sort of the data warehouse. And so I think as long as you make that connection and then get the walk status, and then go through the IOB process. I actually was fortunate with our quality improvement program. We actually got a national QI exemption for all of the work that we're doing, which makes life really easy because that was about a 3-page application.
Yeah.
The IRB process for the RVA is they're contracted with the University of Maryland VA. So it just goes through the same thing I would do normally, except checking the VA box.
That's nice. Sometimes they'll have a completely distinct IRB.
Yeah.
Same question about what kind of faculty appointment you needed to have to be PI submitting a grant.
So the 5/8, now the operational dollar, that's for a research study. For operational dollars, you don't necessarily need the 5/8. So if you're going to apply for one of the career development awards or like a research award, then you need the 5/8. But if you're just getting operations dollars, again, it's that sort of clinical dollars, so dollar in, dollar out. So if you're interested, one of the other ways I got in was actually starting as an intermittent or a fee basis doc. And so that way you get your badging, you get your passwords, you get the ability to understand what the data looks like already. You don't have to do that many shifts, you kind of do it whenever you want to. But then it gives you that sort of in, so that if you do want to then kind of use that as an opportunity to leverage dollars, you can. It's a lot easier to hire you on once you're already an intermittent or a fee basis as well. And there's no strings attached to that, which is kind of nice.
Can you guys speak to, so you talked a little bit about the difference between VA and NIH in terms of priorities and approach. In terms of the review process and how you decide which which funding source you might be interested in, how do you guys approach that? Or what have you done in the past?
I think, at least from my perspective, and you've been more successful than I have from getting HSR&D dollars, but I've been able to broadly fit most of my work under HSR&D, I kind of view, and correct me if I'm wrong in this, but CSR&D is more like sort of the traditional clinical type of research, thinking more about randomized trials, whereas the BLR&D and the rehab is completely outside of anything I'd even be interested in. So really it kind of narrows down to HSR&D and CSR&D, and HSR&D so broadly covers the type of work that we do that it's not really even been an issue to consider CSR&D. I don't know what...
Yeah, the way my center director puts it is that there is sort of a fuzzy line between the CSR&D and the HSR&D, and you could almost spin a project into either, but it's usually based on what you call, what your outcomes are. If you have more clinically focused outcomes, it tends to go towards more the CSR&D side, and if you have more typical HSR&D type outcomes like cost, value, like exit process measures, things like that, then there'll be more HSR&D. I would say that in our center we have, I think we have like, 50 to 70 investigators, and even like the hardcore clinical investigators, the majority of their projects are in HSR&D. BLSR&D, that's very clearly like, that's not patient facing at all. It's like all clinical research, and then the R&D is, very targeted to rehab.
We're happy to stick around afterwards as well, and thank you all for coming. Hope to have you all join on the Thursday calls, and thanks for coming.